A 17 years old present following operative repair of tendon and the ulnar nerve as well as median nerve when she had laceration in the distal forearm. The surgery was done 1 year back. She is now in the hand clinic with unable to achieve thumb abduction and metacarpal flexion, and she has noticed severe clawing of her digits. She has been in occupation therapy for about 1 year and unable to grip things, and she would like to prefer to improve her function. On physical examination, you notice that the patient cannot oppose her thumb to the little finger. Her skin is supple and there is no contracture in the first distal web space. Nerve conduction studies were performed and revealed a combined low, median, and ulnar nerve palsy. While talking about this patient, thumb is a key in providing strength and prehensile pinch and grasp. Opposition is a complex motion involving abduction, flexion, and rotation of the meta-CMC joint, and flexion and rotation of metacarpophalangeal joint. Median nerve palsy deprives the thumb of its ability to oppose. Restoration of opposition requires the presence of transferable functional tendons and to the thumb, and with the thumb should have adequate ability without contractures. At the level of the wrist, the median nerve lies between the flexor carpi radialis and palmaris longus tendons. The nerve lies molar to the flexor pollicis longus and flexor ridgeor profundus tendons. The nerve enters the carpal tunnel between the transverse carpal ligament. In the carpal canal, the nerve may begin to branch to supply the median innervated hand intrinsic muscle. To the function of the thumb, the transfer is called Burkhalter EIP transfer. The transfer of EIP to the abductor pollicis brevis was described by Burkhalter in 1974 and is perfect for the patient with isolated thinner paralysis. Due to low or high median nerve injuries, the transfer achieves excellent thumb abduction, pronation, and metacarpophalangeal flexion. With the patient under general anesthesia or regional anesthesia, tourniquet is applied to accentuate the operative extremity. The planned incision is outlined. A longitudinal incision is made over the index metacarpophalangeal joint. The EIP is identified ulnar to the extensor communis tendon. An incision is then made on the ulnar side of the EIP through the sagittal bands and extended distally. A similar incision is made on the radial side, separating it from extragittorum communis, and then connecting it to the distal incision of the ulnar side. The sagittal bands are then repaired at this point in the operation to avoid extensor lag. Once the distal attachment of EIP is released, a linear incision is made over the dorsal and ulnar aspect of the distal forearm, and the deep fascia is divided longitudinally. The EIP tendon and the muscle are identified and delivered to the proximal wound. If delivery is hampered by adhesions or connection of the EIP to the dorsum of the hand, another incision may be required to free the tendon and muscle belly. Once the EIP and the muscle belly are freed, a small longitudinal incision is made just distal to the pisiform bone, and a subsequent tunnel is created across the forearm from the dorso-ulnar forearm incision to the second incision distal to the pisiform. Care should be taken to ensure that the tunnel is large enough to accept the belly of EIP, or it may prevent full excursion of the donor tendon. The tendon is then passed through the tunnel using a tender passer or sometimes a hemostat. Now, another incision, a second subcutaneous tunnel is made over the palm to the thumb metacarpophalangeal joint. The line of pull is estimated by placing the donor tendon to the proposed insertion site at the distal thumb metacarpal. Regardless of the method of attachment, using the transfer tendons need to be secured fixed in a place. This is accomplished using a bone tunnel or weaving the EIP through the abductor pollicis brevis. The thumb is placed in full opposition of the small finger. The EIP transfer is tensioned and secured Tourniquet is released, hemostasis is obtained, and wound is closed. When the procedure is complete, a bulky hand dressing is applied, which is later on removed and physiotherapy started. This is not the only one way to achieve thumb abduction. A brand technique involves splitting the EIP tendon into two slips. One slip is woven through the abductor pollicis brevis, passed distal to the metacarpophalangeal joint, and then attached to the extensor pollicis longus tendon. The second slip passes subcutaneously across the extensor mechanism dorsally and is attached to the adductor pollicis on the other side of metacarpophalangeal joint. This technique is useful in those patients with complete loss of thenar musculature and unable to metacarpophalangeal joint function and has unstable joint. There is another alternate technique called Royal-Thompson method, also splits the EIP tendon into two slips. One is passed through the drill hole in the metacarpal neck from the radial to ulnar side, with the metacarpal pulled to the highest degree of opposition as possible. The other half is passed dorsally over the extensor hood at the metacarpophalangeal joint and through a small tunnel in the fascia and periosteum at the base of the proximal phalanx. The two slips are tied together. The proximal insertion into the head of the metacarpal serves to assist in rotation of the thumb, while the distal insertion achieves slight rotation of the metacarpophalangeal joint without causing flexion. While talking about the complications with poor results after the apposition tendon transfer, often are due to the adduction contracture of the first metacarpal. This problem may be avoided by release of the contracture prior to tendon transfers, whether it is by surgical or conservative management. Flexure or extension contracture of metacarpophalangeal joint of the thumb often reflects the position of the transfer relative to the metacarpophalangeal joint axis. The transfer should be sutured more dorsally if there is a flexion contracture and reattached more volarly if there is extension contracture. Other common complications with tendon transfer are placing the donor tendons with inadequate tension or placing a repair in poorly viscoized soft tissue bed. These complications, along with web space contractures or inappropriate splintage, can be often avoided if precision handling of the all tendon is done, along with understanding the important general principles of the tendon transfers.